So welcome also from my side. It's great that you joined in again, and I think we have a great faculty today as well, with 4 exciting speakers from basically all over the world, and again from 4 different disciplines to be discussed multidisciplinarily. First of all, I would like to thank the PDL team, who always provides such excellent technical support that we can exchange without any interruptions. And also we would like to thank to the sponsors, foremost Pharma, then also Bio, Novartis, and Implancast, without whom this would not be possible. Again, we will have the presentation, then we will briefly discuss among the respective disciplines, and then in the multidisciplines. And afterwards, we will have the judgment by the international board before we then go on. And hopefully in the end, there will be time to discuss all 4 cases in perspective. Having said all this, I would love to ask now Gundhild Mechtersheimer from Heidelberg to start presenting her case.
Good afternoon, everyone, and many thanks for the invitation to present a case today. It's the case of a 27-year-old newly gravida. She presented with abnormal uterine bleeding, and the resident gynecologist detected on colposcopy a polypoid mass arising from the endocervical side. And she considered the lesion to be benign and performed polypectomy. And on microscopy, we got a specimen measuring a largest diameter 1.5 centimeters, and it was completely occupied by a light brown shiny tumor on lamellar sections. Here you see the entire specimen, and indeed it looks a little bit polypoid, and here are residual mucosal cells, and you see the mucosa is ulcerated and there's some hemorrhage. And the whole tissue looks a little bit blue, and this indicates high cellularity. And indeed, what we saw on higher magnification is a cell-rich spindle tumor. The elongated spindle cells are arranged in fascicles, and sometimes it looks a little bit like a herringbone pattern. In other parts of the tumor, the stroma was highly vascularized, and there was even a little bit of perivascular hyalinization in the tumor tissue. And looking a little bit more in detail, the spindle cells are quite monomorphous. The nuclei only show slight variation in size, but we could find a lot of mitosis here, and here are the next one. So a highly proliferative spindle cell tumor, which morphologically is malignant. We did not detect any necrosis. So there are a lot of different diagnoses for spindle cell tumors in the female genital tract. So we did some immunostainings. The tumor cells were completely negative for cytokeratins. Here you see the residual cervical mucosa. Quite a number of tumor cells stained positive for CD10 and for cyclin D1. But the tumor cells were negative for myogenic markers, here shown for H. Caldersman. So looking at this immunoprofile, it resembles a little bit an high-grade endometrial stromal sarcoma, but morphology doesn't fit so well. And in addition, the tumor cells were homogeneously CD34 positive, and at least subpopulations also expressed S100 protein. In the absence, I have to say, from other neuroectodermal markers like Milan A, HMB45, SOX10, for example. Only very few tumor cells showed expression of the estrogen receptor. Here you see residues of the mucosa, which are strongly positive, but the tumor mostly is negative. And I would say the key 67 labeling index was quite high. So I would like to ask you, what's your tentative diagnosis? I have 5 possibilities: amelanotic malignant melanoma, spindle cell squamous cell carcinoma, high-grade ESS, spindle cell sarcoma, NOS, or you would say, seeing morphology and immunophenotype, they are not yet conclusive for definite diagnosis.
We have 6% for spindle cell squamous carcinoma, 47% for high-grade endometrial stromal sarcoma, 24% for spindle cell sarcoma NOS, and 24% for non-conclusive molecular pathology requirements.
Okay, so I think all answers are more or less right. We have some spindle cell malignant melanomas which do not express melanocytic markers. Spindle cell squamous carcinomas can be without any cytokeratin expression and so on. But non-conclusive molecular pathology required is my favorite answer. And I think we have seen a very monotonous spindle cell tumor, and such tumors are a little bit suggestive for gene fusion. And so we performed molecular pathology using the Sarcoma panel, and indeed this case showed NTRK-3 fusion with this other fusion partner, and our final diagnosis was NTRK-rearranged spindle cell sarcoma of cervix uterine. In the actual WHO classification, these tumors are an emerging entity which are called spindle cell neoplasms, but in this special case, I prefer to call it a sarcoma. I would like to thank Georg Schum from Potsdam, who sent me this case for consultation, and I just would like to ask you if you have the one or other of such tumors. We are just preparing a very small paper on these tumors with extensive molecular characterization. So I would be we would be happy to share this small project with you. Okay, so after the diagnosis was given, whole body staging CT was performed, and the cervix was a little bit distended. There was minimal fluid in the carbon uteri, and some cystic lesions in the ovaries compatible with follicular cysts. But there were no evidence of lymph node or distant metastasis. So my next and my last question would be, how would you proceed in this special case?
We have 17% watch and wait, 17% for molecular targeted therapy, 39% for hysterectomy and salpingectomy or annexectomy, or 28% with combination of 2 and 4.
Okay, so I'm a pathologist and not a clinician, but what was done in Tübingen, because it was not a case from Heidelberg, I think it's okay. They did a modified radical hysterectomy with salpingectomy and a bilateral paracolic ovariopexy, and took a lot of biopsies from different areas of the peritoneum. And on the operation specimen, which I did not see personally, but a friend of mine in Tübingen, there was still residual cervical tumor measuring up to 2.5 centimeters, but there were no other tumor manifestations. And on the CT, on the whole body CT, there were no metastases on imaging. And so the final diagnosis was this NTRK-rearranged spindle cell neoplasia with this TNM state, no vascular invasion or perineal tumor propagation in figure 1b2. And about 3.5 months after the operation, the first follow-up MRE abdomen and pelvis was done, and there was no evidence of tumor recurrence and no evidence of lymph node metastasis, and the next whole body CT will be done in 2 months. Okay. If I have still a little bit time, I would discuss a little bit NTRK-rearranged tumors, but you stop me if it's too much, okay? So the first description of these tumors in soft tissue sarcomas was in congenital or infantile fibrosarcomas in 1998, and it's this fusion, which is found in more than 19% of cases. It's the canonical fusion. But NTRK fusions are found in, as you know, in a variable number of entities, including carcinomas, melanomas, sarcomas, and so on, but they are quite rare. If you look at the nearly 34,000 cases examined by different techniques at the MSK, all the patients had solid tumors. It was only a few cases who had an NTRK fusion. The frequency is a little bit higher when looking at pediatric mesenchymal tumors, but saying overall it's quite rare. But there are some exceptions in addition to the congenital or infantile fibrosarcoma. For example, in secretory breast carcinomas, you have a lot of NTRK fusions, which are more or less canonical. But NTRKs are not the only kinases fused in soft tissue tumors, and I adapted from a paper this scheme. All these kinases, which are highlighted here in pink, can be found in fusions involved in sarcomas, and these kinases they activate the MAP kinase signaling pathway, or like BRAF and RAF1, they are even members of this pathway. And what complicates the situation more, with NGS-based analysis, every day we have a new fusion with new fusion partners, and this is shown here for the NTRKs 1 and 3. Here is our fusion partner of our case, and especially also for ALK1. During the last years, there are some efforts to correlate a little bit more morphology with the molecular pathology, and I think among others, Bernadette Liedl, who is present today, and Christina Antonescu have done a lot of effort and contributed to this. So we can say we have at least 4, and if you would like to separate the last group, you have 5 different groups of morphological patterns, which are also associated with the frequency of kinase fusions. I just showed you the infantile fibrosarcoma. Now the cases which show other fusions than the canonical one are called IFS-like lesions with related kinase fusions, and sometimes they are prognostically a little bit poorer than infantile fibrosarcomas, and a group called lymphofibromatosis like neural tumors, which was also initially described by Antonescu's group. Here you see you have predominantly NTRK1 fusions, while in the other cases, which really look like sarcomas, like our case, a little bit like adult type fibrosarcomas or like MPNSTs, here you have especially NTRK3 fusions, but also other fusions, including the members of the MAP kinase pathway. Only short, the age distribution and localization of these kinase-fused soft tissue tumors is also a little bit different. Naturally, congenital fibrosarcoma occurs frequently at birth in the soft tissues of the extremities, and less common, for example, in head and neck. The IFS-like lesions occurs also mostly in children under age 2. Yet is a predilection of intra-abdominal sites. I think a lot of cases which were called visceral infantile fibrosarcomas belong to this group. This enigmatic group of lipofibromatosis-like neural tumors is also mostly found in children, less common in young adults, and it's mostly superficially located with the predilections to extremities or trunk. And the last group, or two groups, for me it's one group, but some authors separate it in MPNST-like or adult fibrosarcoma-like spindle cells tumors. It also occurs in children, young adults, but frequently also in older people, and the range of age is quite wide. One can find it not only in soft tissues and rarely in bone, but frequently and most in the viscera. In most of the cases, approximately 25 to 30 cases have been described in the uterus, and there are also some cases in the lung and in the GI tract. Looking, and I will just be short for finishing, a little bit the biological behavior of these tumors. Infantile fibrosarcoma has generally a favorable outcome. In EFS-like lesions, they may show an aggressive clinical course. The lipofibromatosis-like neural tumors usually follow a benign clinical course, according to what we know up to now. And the spindle cell tumors, I would say sarcomas, which are fibrosarcoma MPNST-like, have certainly a malignant potential, and some case reports showed widespread metastasis. So I have not yet a lipofibromatosis-like tumor in my collection. These are figures from a paper from Antonescu's group, subcutaneously located with infiltrative growth pattern, mostly spindle cells with monotonous small nuclei, but sometimes there is also nuclear atypia, and the tumors are generally S100 protein positive in addition to NTRK. And still 3 or 4 other slides. This is graph 1 rearranged spindle cell sarcoma resembling MPNST from a 17-year-old male patient. It was up to 9 centimeters in diameter and located on the right thigh. And here you see spindle cells which are arranged in short whorls, and sometimes they are a little bit accentuated around vessels. It's like MPNSTs. And this tumor showed co-expression of CD34 and S100 protein, and had this RAF mapped for fusion. And what's in addition to help in different diagnosis, the charm of kinase-fused tumors might be that they can be targets for small molecule inhibitors. And once again, you had already seen this scheme. And here are a lot of TKAs, which I have to say have not yet all been approved by the EMA or the FDA for clinical use in children. But this opens new futures, I think, and most of you know this already. And I would finish with the last case from our series, a 6 weeks old boy. He had a congenital infantile fibrosarcoma with a canonical NTRK fusion. Here is the typical morphology, and the tumor was also a little bit cystic, and it was a large tumor which was inoperable. And the boy was treated in a clinical trial, or is still treated in a clinical trial with erlotinib. And here you see the first image before therapy. It's the upper arm and a very, very large tumorous mass, which reaches the humerus. And 8 months after beginning therapy, it's shows a considerable shrinkage, and this goes on also for additional months later. So I would like to conclude. This group of tumors, which I just presented, are emerging and steadily growing new subtypes of soft tissue tumors They are associated with a wide spectrum of morphologies and grades. They show either variable co-expression of CD34 and S100 protein, as I showed in some cases, or they show a non-specific immunoprofile, but they are monotonous. So think about a translocation-associated sarcoma. The range of biological behavior is also very, very wide, and as just shown, they may be suitable to targeted therapies in metastatic or locally advanced settings. And I think we as pathologists and the clinicians should consider such tumors in a suggestive morphological and clinical context. So with a view on our old castle and our newer institute, I would like to thank you very much for your attention.
Thank you so much, Gundhild. Truly appreciate. Two things for the sake of time, and because we will get back to this type of tumor later today, I suggest that we focus on, let's say, the diagnostic part of this tumor. And I invite now Beata Bode from Zurich, Bernadette Liegel-Arzwanger from Graz, and Brandon Dixon from Toronto. He is also among us. Now we see you. Maybe you can discuss, diagnostically, should now everyone get a testing for NTRK? Please go ahead.
So thank you very much for this excellent talk and for this presenting this nice case. I think you have really nicely shown us that we need a combination of morphology, immunohistochemistry, and NGS to get to the right diagnosis. And if we should have closed all stuffs with CD10 and cyclin D1, maybe somebody who is not familiar with GYN tumors would have said it's a high-grade endometrium stromal sarcoma and would have been very wrong, because I also think that a lot of GYN pathologists are not really familiar with a lot of this immunohistochemical panel we usually use in soft tissue pathology, and I think that's great to show that we need more immunohistochemistry. And what is your point of view? I have seen now several cases without really a lot of CD34 and even without S100 also showing NTRK fusion. What would be the hint for you to go to NGS? It's only then we have a monomorphous morphology without the specific immunohistochemical profile, and then we go further for Archer bundle or other NGS testing.
Yes, that's it. I think if the tumor by morphology looks a little bit suggestive of translocation-associated sarcoma, as you just said, and I think all the monomorphic tumors, especially the spindle cell and round cell ones, so I would do it. But the other question is will there in the future, if you have a longer follow-up on considerable series of cases, will there be some differences between NTRK-fused tumors with CD34 and then character immunophenotype or not? So I think it's still difficult to have the exact subtype of these tumors.
Okay. And do you think that we will keep with this splitting up NTRK fusion tumors from red fusion tumors, from PIRA fusion tumors, or do you think that we will come up maybe in the next WHO with like one group of fusion sarcomas, and then our part as morphologists will be to grade them, because we have so many different morphologic aspects, and I think more will come up. So makes it sense to put all them into special groups, because Christina Antonescu made a tremendous job by separating out all of them. But I think most people are now really, really confused by splitting this into the subcategories.
So short for me, because I think Brendan Dixon could also comment this. I think the lipofibromatosis, like neural tumors, which look rather blunt, will be another. But I think it could be that we put all the spindle cell sarcomas, and I would call them sarcomas and not spindle cell neoplasms or tumors, together under the headline kinase-fused tumors. Probably, but
Brendan, do you want to?
Yeah, I think that's a great question, and I mean, there's always that the motivation in pathology or the division of lumpers and splitters, and I think to your question, I mean, it's something that we all wonder about, and at the moment, I think that there's insufficient really evidence to know for sure, and I think analogous to the low-grade and high-grade endometrial stromal sarcomas, where you can have a morphology that fits better with one than the other, and the molecular is ultimately what tells us, you know, the diagnosis. I think that we're probably going to need a bit more of a convergence of not just the molecular and morphology, but perhaps methylation. And I suspect that there are other variables at play that we probably are not quite there yet. Kind of analogous to EWSR1 and ATF1. You know, there's half a dozen tumors with completely different morphologies and immunophenotypes and the exact same fusion. So I think that there are more elements that really need to be identified before we can start coalescing together. But I wouldn't be surprised if many of these subsets do come together. And if I may, I mean, this is a splendid case, and you know, the beautiful morphology with the 34 and the S100. I mean, it was just textbook. And similar to your lab, we always defer to next generation sequencing. I was wondering if you could just briefly comment on the role of the pan-Trk immuno in this context. We don't use it; we just go straight to next gen. And I was wondering how you feel.
No, we don't even have.
Just coming.
No, we don't.
There are some questions, let's say, from the audience, and I think that's more for the non-pathologists. But of course, these are the burning questions for the non-pathologists. Well, which lesions do you screen for NTRK fusions, and can immunohistochemistry replace, or let's say the NGS, or let's say what about the sensitivity? Maybe Beata, you want to jump in there, or anyone from you?
Well, this is, you know, the strategy to arrive at the diagnosis may differ, but finally, you know, sooner or later we have to do some genetic testing. So the immunohistochemistry kind of, you know, you have a result next day. So if it is, you know, like flaming positive, it's more or less, you know, what to expect on the NGS, but you wouldn't skip the NGS at the end and make your diagnosis. And you know, that's all. Sorry. Well, in the gynecological pathology, I think there is still a lot to discover, because, you know, unless this is a quite typical leiomyosarcoma, everything else looking kind of different is for me an indication to go for NGS, because, you know, there are so many undetected translocation yet in those tumors. Which were just lumped into high grade or low grade or whatever, and, you know, nobody really knew how to call them. So this is one point of this gynecological sarcomas, and the other point, you know, how do you select? Immunohistochemistry is quite easy. So, you know, if the diagnosis is not obvious, you can always do it. So immunohistochemistry is no big deal. Usually it's negative. So, you know, unless you know it's going to be something very special, which is, you know, like 1% of your of the daily routine, except when you are in the center. So, you know, it's I don't do it all the time. I do it if I don't really know what it is, and waiting for the, you know, molecular.
Do the other three agree
for immunohistochemistry.
Do the other three agree with this statement?
For me, it's a screening mark. Also, I do it for screening, but especially in the GYN tract, you cannot rely on it, because leiomyogenic tumors very often also have a positive expression for pan-Trk.
Yeah, exactly. That's the other side.
Like for me, it's a screening, but I go ahead with NGS testing if the inbox is not really fitting to a need category.
And it's also, you know, it's maybe important what the partner is. So, you know, even if you have immunohistochemistry or whatever. So we are at the level or the stage of splitting, and, you know, unless we know what to lump with what, we have to split and call the thing, you know, what it is. And it also will depend with the development of the medication which are offered for clinicians. So that's probably, you know, the interplay between the clinical part and
I really
pathology.
Hate to interrupt. I think we need to extend the discussion onto the forum later, and I think we need to move on. Let's switch now to Norbert Dion, who is presenting the surgical case of today's webinar. Thank you so much for your contributions.
So I'm really happy to be involved with this webinar, and I would like to thank Bruno to have invited me. So today the case will be, doctor, I think I have a neck problem. So I have no conflict of interest. So this is a 69-year-old gentleman, semi-retired physician who had been having knee pain on his right side for the last 5 to 6 years. And this has been getting worse over the last year, and he had developed an obvious antalgic gait. So it was impossible for him to sleep in the supine position in the last few months, and he saw a few MDs and orthopedic surgeons, had some knee cortisone injections, and also had a knee scope, so a surgery. And then one surgeon decided to examine the hip and perform x-rays, and you can see that definitely there is a neck problem. So besides this obvious pathological fracture, we can see some cortical hypertrophy, and we can see some calcification in the medulla that would be suspicious for chondroid matrix. And we can also see something that would look like soft tissue extension. So on the CT scan, we can see clearly the pathological fracture and the chondroid matrix. And we can see on the right the periosteal reaction and the suspected soft tissue extension. On the MRI, especially on the stir sequences, you can see the extension in the soft tissue. And we also can see some abnormal signal in the distal iliopsoas muscle and tendon. And with gadolinium enhanced images, we can see that the enhancement is peripheral, so that could be a fluid collection coming from the path fracture. And we can see clearly a pattern of enhancement that would suggest a chondroid origin for this tumor. So staging studies were performed, a bone scan and a CT scan of the chest, abdomen, and pelvis. All studies were negative except for this femoral lesion. And a biopsy was suggested, not surprisingly, of a chondrosarcoma. So things to consider here. So we have a chondrosarcoma that's involving the proximal third of the femur. There's presence of a path fracture with hip joint contamination. And there are concerns regarding a fluid collection along the iliopsoas tendon. Besides this, the major nerves and vessels are okay, and the staging studies are negative. So my question to you here is, how do you want to proceed? So either with limb salvage, with reconstruction, or without reconstruction, or an amputation that would take the form of an external hemipalectomy.
We have 81% for limb salvage with reconstruction. No one for the option without reconstruction, and the amputation with 20%.
So we also decided to go on for limb salvage. So here, that would require an extra-articular resection since the hip joint was contaminated. And many years ago, we would have gone for a total resection of the acetabulum, but Gans was an orthopedic surgeon based in Switzerland, in Bern. He described a periacetabular osteotomy that was used for hip dysplasia, where basically the osteotomy lines were as followed. it was still extracapsular, but the big advantage was you could keep the posterior column in continuity, which can be an advantage for reconstruction. So we can see here the patient lying on his side, and this is the incision we usually use for these kinds of resection. And a few hours later, you can see the surgical specimen, the proximal femur en bloc with the acetabulum. And you can see on the right, holding in my right hand, the iliopsoas muscle and tendon with the suspected fluid collection. So on final pathology, it was a grade 2 chondrosarcoma. The margins were negative, and there were no tumor found in the iliopsoas bursa, although there were some cartilage fragment, but without any atypia. So the second question is, how do you want to reconstruct this defect? So either with an APC, so use of an allograft, a pedestal cup, or commonly called the ice cream cone prosthesis, a saddle prosthesis, or a patient-specific implant, or any other surgical avenue. I realize this is a more difficult question for non-surgical.
Yeah, but we have 67% for the patient-specific implant. We have 13% for allograft prosthetic composite, and for all other options, 7%.
That's interesting. So definitely PSI are trendy. So as you can see, there are several options available for reconstruction. So the saddle prosthesis, I think, has fallen out of favor because of a high complication rate, mechanical complication rate. The pedestal cup or ice cream cone prosthesis, I think, has been used more in Europe, but probably less here on this side of the world. And the APC, so using the allograft, is certainly still an option. And the patient-specific implants, for those who are not familiar with this, are usually with the help of the CT and MRI, there can be a model or a computerized model, and then you can have patient-specific cutting guides, and then you use this to create an implant that's custom for the patient problem. So several options, and these, of course, are influenced by the extent of resection, both on the pelvic, mostly on the pelvic side, but also on the femoral side in this case. And this, of course, is really influenced also by the surgeon's experience or the team's experience. In this case, I have had the pleasure and chance of working with Etienne Belzile, who's a superb hip surgeon here in Quebec City, and we've been collaborating on these cases for almost 20 years. So of course, this takes into account in our decision. So we can see here a patient that we did an operation 11 years ago using an APC reconstruction. Of course, there's an allograft. It's obscured by the amount of metal that's in there, but the patient is still alive without disease and functioning 11 years later. The problem with the allograft is it takes longer time to shape this to match the acetabular defect, and usually this is done during the operation, although this could be improved by the use of patient-specific cutting guides. The allograft might be another risk factor for infection, which we dread for these kind of surgery. And there's also a risk for graft non-union or lysis with time. So back to our patient. In this case, we elected to go for an acetabular reconstruction using an anterior column plating, and then using augments of trabecular metal, which is a metal that has a high affinity to bone. And we used an augment on the dome and also on the posterior column. And this helped us to support the trabecular metal cup. So these images are provided, this is another case, but these images were provided to me by Dr. Frank Sim, formerly from the Mayo Clinic. And you can see they were trialing here for the use of a similar kind of a reconstruction. And first of all, usually the trabecular metal cup is fixed to the remaining bone, and we try to get as much host bone contact as possible, and then use also as many screws as it is possible. And then you can add the augments that are fixed with screws to the host bone, and applying cement in between those to assure a stability of the implant. So the patient has been was operated on about 2.5 years ago, so he's still free of disease. Although I realize this is a short-term oncological follow-up for a chondrosarcoma. So we have not had any mechanical problems, and the functional status of the patient is that he walks without any assisted device. He has no limitation with the sitting position, and he's able to walk outdoor for more than 1 hour. So the patient was, and we cannot overemphasize the importance of physical therapy and a regular exercise program, because these patients, usually when they come to the operation, they have weak muscles, they've been having problems for months or years, so it takes time, and I usually tell patients that it's going to take 12 to 18 months so that they can really have their final functional result. So the patient was kind enough to send me a few videos. So he's now, like I said, 2.5 years post-op. So you can see him walking with a very slight Trendelenburg gait, which is, very reasonable since the proximal femur was resected. And you can see him climbing stairs, and he's still able to get some flexion of his hip, active flexion of his hip. You probably is using also his quadratus lumborum to do this. As you see, he's moving his pelvis as well, because he did have his iliopsoas tendon removed. And you can see him in our beautiful weather at the junction of the winter and spring in Quebec, and he's walking just outside of his house. So the take-home messages are that a Gans osteotomy is a useful method in our surgical toolbox to do an extra-articular resection of the acetabulum. It has the clear advantage of keeping the posterior column in continuity, and this can also be used in very specific acetabular tumor where the posterior column is not involved. So type 2 internal hemipelvectomies are always a challenge, and as you could see, there are several options for reconstruction in these cases. So thank you for your attention.
Norbert, I truly congratulate you for this excellent outcome in this patient. I invite now Michael van der Sande from Leiden, Konstantina Errani from the Rizzoli Institute, Frank Traub from Mainz, and Filip Funovic from Vienna, if he's still here and not yet in the urgency. So how is your approach in your centers with path fracture, intra-articular path fractures of the proximal femur? How do you handle this? Maybe you want to comment on that based on just what Norbert presented. Michael, do you want to start?
So no, I think this was a challenging case, and maybe you did the correct surgery, I think. I mean, I think that a custom prosthesis could be an option, but not in chondrosarcoma cases, because I don't know in your country, but in Italy you have to wait 1 month to have a custom prosthesis. So chondrosarcoma is not chemosensitive tumor, so I think it's better to do not wait 1 month to have a custom prosthesis. So in a chondrosarcoma case that can grow, and you have to perform surgery. I think another option maybe could be a ring, and that can and so you can try to do a reconstruction of the pelvis with a ring. But I think that your choice was the best choice. And I have a question. I just have a question. Did your pathologist find a tumor inside the joint? I mean, the articular hip joint?
Yes, they did. Of course, it was not a large amount, but just the fact that the tumor had braked inside the capsule in the neck. So, but we did find some tumor, yes.
And it was the same pathology as before?
Yes.
That's another question from the audience. Frank, Michael, Philip?
Yes, I'm unmuted now. Thank you. Honored to be here. Great case, Norbert, and really well done on the reconstruction. There are so many ways to Rome or Quebec, but many of them end up with happy patients if you get the tumor out in one piece. And I think that's the main take-home message in a chondrosarcoma. Anywhere, especially around the pelvis, you get one shot. You can't really miss, so you have to take everything out. If you would have done an external hemipelvectomy, you would also have made a good choice from an oncological point of view. But I was also very much in favor of saving the limb in this case. I would ask also to the rest of the panel. I used to do a lot of Gans osteotomies, initially just blind, and now with computer navigation or surgical guides. And doing these resections now, if you use a guide, you can actually kind of reconstruct the pelvis easier because you have a predefined resection, and you can use either bone or metal to reconstruct it. So that's just something I was thinking about when I was looking at your great case. Thank you very much.
Thank you.
I fully agree with what has been said. I think it's a very good option that you chose for reconstruction in that case. And I like the idea of especially in the chondrosarcoma where you need to react quickly of a off-the-shelf type of reconstruction. Maybe just in addition, if we treat radiosensitive cases, especially in the pediatric cases, I just like the idea of re-implanting the irradiated autograft, for example, in Ewing sarcoma. I appreciate the advantage that still with secondary necrosis of the femoral head or with secondary arthritis, you can still get a normal implant inside the replanted autograft. But I think for non-radiosensitive cases, as the one you showed, that is a very good option. Yeah.
So basically, all agree, Frank?
Yeah, I also totally agree. The only thing is with the custom-made implant is always the time, and if the patient already has a fracture and is in pain, so that's a good choice not to choose a customized implant. And then you have to use whatever is due to you and what you feel comfortable with. And then I think there's no right answer, but there's also no wrong answer. Whatever some of us will choose, if he feels comfortable and confident with it, it's probably the right choice. And always try to save the limb. So, and even in this case, where you could argue, is it really necessary to do extra-articular resection? The pathologists show you that it was the right choice, but sometimes you're lucky and maybe you don't need to do an extra-articular resection. But of course, you always will have the problem that if you approach the hip joint, that your fracture is falling apart and then you split the tumor all over. So probably a better idea to go with an extra-articular resection in the first step.
Michael, please.
Yeah, I have a question to the group. I understand the need for histological confirmation before an external or an extra-articular resection, or even worse. But the risk of seeding in cartilage tumors may be a little bit higher than in other cases where you have radiation or chemotherapy to aid the treatment. So I was just wondering, does everyone still do a biopsy before and confirm that it's cartilage, or just take it out because it looks like a cartilage tumor and it's in the hip and it's outside the bone, so it's malignant?
I would go for a biopsy anyway. So there's no way to blame somebody for a biopsy, I think. And the other thing is sometimes it's a weird kind of metastasis. So, and then probably you have another option, or maybe there is chemosensitive kind of tumor. So why not go for a biopsy?
So I think that's a continuing debate among the surgeons, but I think that would be interesting to hear the opinion of the pathologist and of course of, let's say, of the advisory board. Jean-Yves, Javier, Axel, Beata just joined in. Jean-Yves, we can't hear you. I know. But maybe Beata, you wanna?
Okay,
I
could get activated. I think that's a very important remark. I'm very much looking for a time where we can do molecular diagnosis on the peripheral blood, i.e. liquid biopsies to confirm in front of what is an obvious image, something which is molecularly speaking, documenting that neoplastic disease is ongoing. Because I think this question that you raise is very relevant, probably not only for this specific tumor, but for all sarcoma.
So in terms that it's not only, let's say, the surgical view, because of course it's easier, but let's say in the context, it's, let's say you opt for, let's say, getting biopsy before any treatment.
We do because that's a rule. But frankly, if there was one way to get with this typical image, with, I don't know, P53 or circulating DNA with obvious molecular alteration, which tells you that you have a disease, a neoplastic disease, which is ongoing. And I know all the limits of what I'm saying. I think that would be a question to be addressed and worth addressing, because I don't underestimate the risk of dissemination with biopsy. Nobody really knows, actually, because these are the rules.
That's a strong point. Go ahead.
I don't think that we can have a dissemination during biopsy. And I think that if I have to perform a surgery, a challenging surgery, like in this case, I want to be 100% sure that it's a chondrosarcoma. I'm sure that it was a chondrosarcoma, right? But sometimes...
let's listen to the pathologist.
So yeah, if I make
I want to diagnose this before the surgery.
You know, contamination is, you know, if you have a fracture, if you have pathological fractures, so no, everything is more or less contaminated anyhow. And so that's how so important, you know, that the correct person kind of plans the track for the biopsy. So for me, it's no question that the biopsy has to be done. And, you know, you can always have something surprisingly like, you know, the differentiation, small side of the differentiation if the radiologist and the surgeon plan the biopsy correctly. So I wouldn't skip the biopsy part. And of course, for cartilaginous tumor, we don't have, you know, any molecular markers. And also the heterogeneity of the tumor will not be depicted by the liquid biopsy for some time now. So rather radiology will be important in this respect to pick the correct site to sample for biopsy. But I don't think that, you know, that you have
any comments from Emanuela, Axel, and Javier?
I think biopsy remains mandatory. It's complex to make a diagnosis of chondrosarcoma only based on radiological assessment. Okay, it is vast majority of cases you can see it is a chondrosarcoma, but you cannot make a grade system in case of aggressive grade 3 in younger population, not 69 years like that, but 50 years old. We discuss neoadjuvant chemotherapy, even in grade 3 chondrosarcoma. So to make a radical surgery before any biopsy is complex.
Thank you so much. Please.
Yeah, I trust my surgeon to assess the risk benefit of a biopsy in this area.
Thanks so much. Specifically to Michael, because raising such an important question, because among surgeons, cholestatic tumors, this is always again, being discussed. But I think it's specifically interesting now to see all the disciplines, having their own view on this, and I'm very happy about this discussion. I think also, again, Norbert, thanks so much. Awesome case. Let's move on now to the case from radiation oncology, Andrew Bishop from Houston, MD Anderson. Please, Andrew.
Wonderful. Thank you so much for inviting me to present at the Sarcoma Academy. I selected this case particularly because of how multidisciplinary it is, and I'm going to take a unique spin on the discussion. Halfway through, I'll stop so others can comment as to what they think that their treatment approach might be. So this is a case of a 32-year-old male who presented with pelvic pain. He initially presented with kind of this mid-pelvic pain over the course of 2 to 3 weeks that slowly was worsening. He started to integrate over-the-counter medication and sought out some physical therapy to try to improve that, but it continued to worsen, and eventually he developed some numbness of the genitalia and perianal region, which of course this prompted a MRI of the L spine and pelvis. What that showed here, you can see on this representative coronal and axial stir-weighted image, a fairly well demarcated mass in that left pelvis with extension into the left gluteal region. This was biopsied, and the biopsy came back as an extensively necrotic, likely high-grade malignancy. So a repeat core biopsy was obtained, which confirmed a high-grade pleomorphic spindle cell sarcoma, which was MDM2 negative. He decided to transfer his care to us at MD Anderson, and over the course of a couple weeks in that transition, he became increasingly immobile, unable to sit or stand. The pain was excruciating, and as you can see here on the repeat MRI, the tumor was rapidly growing, both intrapelvically as well as extrapelvically. So here are some representative axial slices. Again, you can see a well demarcated kind of necrotic mass predominantly in that left pelvis, displacing the pelvic organs to the right, with extension through the sacrosciatic notch, as well as extension through the obturator foramen into the gluteal region and left upper thigh. So this 32-year-old male has a large 19-centimeter high-grade soft tissue sarcoma of the pelvis with extension into the gluteal and thigh region. And also what was noted on his imaging was suspicious metastasis in that right supra-acetabular ileum. A biopsy of that was obtained, and that was confirmed to be a grade 3 chondrosarcoma. So 2 synchronous sarcomas, a soft tissue sarcoma in the left pelvis and a chondrosarcoma in the right pelvis. Systemic staging was negative for any evidence of metastatic disease. So the question for the audience, what next? Would you do surgery alone, surgery for both tumors? Would you use chemotherapy or perhaps consider radiation therapy?
We have 45% for option D, pre-operation radiation. We have 20% for surgery alone for both tumors. We have 15% for chemotherapy, and we have 10% either for surgery alone or for radiation in both tumors.
Interesting. So I think that this, this case is pretty complicated and highlights certainly the importance of a multidisciplinary approach to the patient's care. I would be curious to kind of stop the presentation here and particularly get input from, my medical oncology and surgical colleagues about, their approach to this type of case, whether they would use chemotherapy and what surgery looks like, considering these two tumors in and of themselves versus together. So I'll invite.
I'll ask the panel to join in again. Jean-Yves, Axel, maybe, and Javier, do you want to start? We still do not hear you again.
Yeah, now my sound is activated. That's a fascinating case.
Yeah.
I would consider to remove the small lesion and to start chemotherapy for the large lesion. That chemo and then radiotherapy. But I think all options are very valid, frankly.
What would the surgery look like to remove that chondrosarcoma?
I mean,
Constantino, do you want to jump in there?
Considering the age and the high grade for the two sarcoma localizations, the big gross tumor in the pelvic, it is an emergency situation, and I'll be in favor to start induction chemotherapy because it's a young, 32 years old. We have time to reflect on the surgery in the second time. The chondrosarcoma of grade 3 or STS of grade 3, doxo polychemotherapy regimen would be, it's an option. I'll be in favor, but you are a radiation therapy, so
maybe we will discover that that also chondrosarcoma responds to small chondrosarcoma can respond to chemotherapy. No, I agree that I would prioritize the huge soft tissue sarcoma of the small chondro, and hopefully won't grow too much over time.
So if you were to start with induction chemotherapy, what chemotherapy would you use?
Usually the same chemotherapy we are using in osteosarcoma.
Yeah.
But obviously we don't have the evidence level of osteosarcoma in chondrosarcoma. This is true. But yeah, there are some very indirect evidence that could be beneficial for patients, especially in grade 3. But it's true that the level of evidence is not
and the other thing is when you have a story of two different soft tissue sarcoma, you can think about Lee-Fromeni syndrome of whatever. So the use of radiation therapy could be not useful in this kind of presentation. We have to be careful.
I mean, I'm a surgeon, so I don't know. We can have a different approach, but I think that my approach was radiation and surgery for the soft tissue sarcoma, so radiation before and surgery. And you know, the lesion of the right pelvis doesn't look like a grade 3 chondrosarcoma. Looks like, I mean, maybe grade 1 chondrosarcoma, I don't know. But I think the surgery is pretty easy. So I think radiation and surgery for the soft tissue sarcoma and surgery for the chondrosarcoma of the right pelvis.
Michael, may I ask you at this point your opinion, your surgical opinion, and then we switch to Brandon.
You see here the problematic of mesenchymal tumor worldwide. You have maybe 20 experts and it's 20 advice difference for one patient.
Yeah, and that's,
so
and
Michael,
that's
please.
I think it's true. I hope you can hear me, but I think we should treat first what kills first. And in this case, the cartilage tumor doesn't look like a very malignant one yet. So we have time to treat the large tumor first. Yeah. And if the patient is doing well, in the end, we can do some more surgery.
Yeah, I agree.
The smallest is a grade 3, right?
Yeah, that's correct.
Brandon, can you comment on that, please?
Sorry, if, at the risk of sounding like a difficult pathologist, a couple of things about this are unusual. I mean, A, you've got two diagnoses, and B, the patient is very, very young for chondrosarcoma. Yeah. And when it happens, it's really, really strange. So before discussing any management plans, I would probably want to go back and re-review the pathology and make sure that the diagnoses are correct, because there are a couple of things here that just don't seem, you know, I guess correct in this context. So I'm a little bit troubled by the diagnoses, and I probably want to go back before treating and make sure. And then I think this just speaks to the benefit of having a multidisciplinary discussion before planning treatment and having expert review not only of the surgical plan and the radiology, but also the pathology as well. But yeah, my 2 cents is I'm skeptical of the diagnosis, and while it may be correct, I'd still want to see it myself.
Now, at this step, I would like to ask further radiation oncology opinions, Tom and Gabriela, specifically in light of what Axel brought in, you know, the potential of having the diagnosis of a Li-Fraumeni, for example.
I thought that was a very good point. There's a 32-year-old with what looked to be 2 different lesions. So I think testing for Li-Fraumeni would be appropriate. And I would agree with Constantino that I think that the large left pelvic lesion needs to be addressed first. It's large, and that needs to be addressed initially. And I would favor starting with chemotherapy, and you can get the genetic testing done while that starts.
Without radiation oncology?
No, I think it would likely follow with radiation prior to the attempt at resection, but you get a sense for what the chemotherapy response is, and then you can get genetic testing in place in terms of if that's going to impact the radiation if the patient has Li-Fraumeni syndrome.
I agree with Thomas.
Thank you. I think all those were excellent points, and in the interest of time, maybe I can tell you what happened.
Awesome.
Please all have to switch off their microphones.
And the winner is
Andrew.
All right. So I think the group made some excellent points. I mean, the pathology comment was well taken. We reviewed the pathology, had this discussed multiple times to ensure that what we thought we were treating is in fact what we were treating, and ultimately that was the decision to move forward with the treatment as 2 synchronous sarcomas, a high-grade soft tissue sarcoma and a chondrosarcoma. So we recommended to initiate neoadjuvant chemotherapy for the soft tissue sarcoma and monitor the chondrosarcoma. The patient received 6 cycles of adriamycin and ifosfamide with, as you can see, a quite measurable favorable response, including dramatic symptomatic relief. Most of his pain went away. He was able to ambulate again and start getting back to some semblance of a normal way of living. After chemotherapy, the question became, what about local therapy? How do we address the soft tissue sarcoma? Do we address the chondrosarcoma? Do we use radiation? Do we just do surgery? And part of the discussion was that to address both of these tumors surgically in opposite sides of the pelvis would be, have a significant impact on his quality life and function. So we decided to do preoperative radiation therapy and surgery for the soft tissue sarcoma. And we ultimately also decided that I was going to treat the chondrosarcoma with stereotactic radiation as a way, not necessarily for long-term forever control, but as a way of delaying the need for any surgical intervention for that while we managed his soft tissue sarcoma and he recovered from that. So a couple quick comments from my radiation oncology colleagues, things that we consider when treating a tumor like this. So this tumor is in 2 different kind of anatomic areas. It's in the pelvis as well as in the extremity. So when we think about contouring to cover those microscopic margins, for retroperitoneal and pelvic soft tissue sarcomas, the recommended CTD expansion is 1.5 centimeters. But as that tumor moves into the proximal thigh or gluteal region, we have to start thinking about larger longitudinal expansions, upwards of 3 to 4 centimeters in those locations. Also importantly, during radiation, doing some sort of volumetric imaging is important. This was recommended in recent guidelines published by ASTRO for the management of soft tissue sarcoma. And as you can see for this tumor specifically, it was important because the tumor continued to shrink during the course of preoperative radiation therapy, which allowed us to do an adaptive plan, account for that shrinkage, and shrink down our margins further to spare those pelvic organs some of that dose. Additionally, because we decided to treat both of these tumors with radiation therapy, you have to think about the overlap and accounting for different doses and fractionation. So this was the plan for preoperative radiation therapy. This was the stereotactic radiation plan, and as you can see, as those two plans meet, there is some overlap. That's important to think about what those normal tissues are getting in that context. So specifically using the example of the nerves, that sciatic nerve that's sitting right there, when we think about stereotactic radiation, the Dmax on that nerve was 25 gray over the course of 5 fractions, which means that there's a higher biologic dose. But when we account for that biologic dose, the equivalent dose delivered to that nerve was 44 gray. Now, if we think about the conventional preoperative radiation plan over 28 fractions, that nerve was getting also a Dmax of 25 gray, but because it was over 28 fractions, the dose per day was quite a bit lower, meaning it received a lower biologic dose equivalent of 18 gray. So accounting for those two doses together, it was a total of 62 gray, which theoretically is a fairly safe dose for a peripheral nerve. So these are just a couple things to keep in mind from a radiation standpoint that I wanted to highlight with this case specifically. So the patient tolerated the radiation well, had no increased toxicity from the stereotactic radiation. He then went on to undergo an en-bloc resection with a type 3 internal hemipelvectomy. My surgical colleagues tell me that the lysis of adhesions to the pelvic contents was quite a procedure to get those removed and took a lot of painstaking time to do that. The surgery was done from an anterior and posterior perspective, as you can see here on the surgical images, or on the surgical photos. The pathology of the surgical specimen was a high-grade pleomorphic sarcoma measuring 10 centimeters with 90% treatment effect and ultimately negative margins. Postoperatively, he recovered, but it was a little bit complex. He did have DVTs, PE, had a small bladder leak, and underwent inpatient rehab for quite some time to get back to his a relatively normal way of functioning. 1 year later, he had good quality of life. He was NED from a soft tissue sarcoma standpoint and had a stable treated chondrosarcoma. However, 6 months later, there was some imaging evidence, as you can see on that MRI, of suspicious progression of the chondrosarcoma. That was biopsied, which revealed an atypical spindle cell proliferation with sclerosis and hemosiderin deposition. I had another poll, but I think in the interest of time, I'm going to bypass that. Given the suspicious biopsy of the progressive areas of that chondrosarcoma, we referred him to IR for a repeat core biopsy, as well as cryoablation to try to maintain some local control of that tumor. Repeat biopsy did come back as a conventional grade 2 chondrosarcoma, and they cryoablated that lesion. At this point, he is 4 years out from treatment. So this 32-year-old had 2 synchronous sarcomas, a 20-centimeter high-grade soft tissue sarcoma treated with neoadjuvant chemotherapy, preoperative radiation, and a complex surgical resection. The smaller grade 2-3 chondrosarcoma in the right supra-acetabular ilium was treated with SBRT, which recurred after about a year and a half and has remained stable after cryoablation. So with that, I will stop my presentation if anyone has any additional comments they would like to make.
Andrew, what a great case, really fantastic. Thanks so much. What a contribution. You see the reactions, just awesome. Any comments on that, or maybe specifically also radiation oncology wise in terms of contouring, maybe something to share also for non-radiation oncologists? I thought that was a really, let's say, for me at least, interesting planning, very detailed, very good. Any comments?
Andrew, Tom Delaney, that was a fantastic case. Thanks for sharing it with us. In terms of the radiation dose for the stereotactic radiation for the chondrosarcoma, I think, as you mentioned, that was really kind of a holding dose. I mean, 25 gray and 5 fractions is really kind of a preoperative kind of dose. There is information on using higher radiation doses for chondrosarcomas, which biologically are in the 70+ gray range for standard fractionation with probably a higher rate of anticipated local control. Combining ablation with radiation, I think, is a very interesting prospect that's also being investigated.
Yeah, thanks, Tom. So the dose to the chondrosarcoma actually.
Joey, we hear you typing. Maybe you can switch off the camera. Excuse me.
So the stereotactic dose was actually 40 gray and 5 fractions. I was just highlighting the dose to the nerve.
Okay, sorry.
Your point is well taken. There's a lot of doses that could have been used, and maybe we could have delivered an even higher dose for perhaps better durable control.
Further comments?
I have just a comment. In this case, with the staging was negative, we will do radiation therapy after the second cycle and just 3 cycles of chemotherapy.
I'm still not sure regarding the diagnosis. I'm not. I mean, you know, the MRI looks like a low-grade chondrosarcoma or enchondroma. I mean, this is my point. So I mean, this is not a radiosensitive tumor. If it was grade 3 chondrosarcoma, I'm not sure that it was possible to control the lesion with radiation and cryotherapy. So I don't know. This is only, you know.
Yeah. Joanna?
I just wanted to ask if you have seen any wound complications, wound healing complications after the radiation in this patient.
He did have some, not necessarily external wound complications. He recovered well from that, but he did have a bladder leak, which, you know, with a complex slice of adhesions, I think that the chemotherapy, the radiation, the complex surgery all kind of contributed to his slower than typical recovery. But in terms of true, you know, wound complications, he did not have any.
Okay, thank you.
Jean-Yves?
Yeah, I was wondering about the compared genomics of the different diseases which were biopsied in terms of molecular alteration. Could you get something which could be helpful for the nosological classification?
Are you asking if molecular testing was done on the tumors?
Yeah, P53, RB, other mutations which could be relevant to help classifying, because that's really a complex histological case. I mean, I don't know what this, well, we have all doves on the histological classification of our disease, but in this case, that's very fascinating, whether this is clonal or multiclonal or whatever. And it would be interesting to see whether you have shared or clonal evolution of the different diseases.
I don't recall off the top of my head what molecular testing was done, and unfortunately, I didn't pull that for the audience. So, but that's your point is well taken. That could have helped firm up the diagnosis a little bit further.
Any comment from the pathology side, Brandon, Beata?
I think it's an excellent point, and I mean, obviously the French sarcoma group is leading the way when it comes to molecular testing in a conventional way of mesenchymal tumors, and I think IDH testing would have been quite helpful in a case like this. It would have been very easy to do. I'm sorry, perhaps I missed it, but what happened about the germline testing? Was that pursued?
Oh,
yeah. It was pursued prior to I think even before he had presented to MD Anderson that had been initiated, and that was negative.
Oh, yeah.
Okay, well, great discussion. Thanks so much. Great case. Awesome. Congratulations. Let's move to Emanuela from the Rizzoli, and you are presenting the 4th case today.
Okay, so I'm very glad to present the last case, and it's a foot lesion, and I think requires a lot of your inputs. So okay, so it was a 30-year-old which presented last year with an increasing pain in the foot and functional impairment. This is the MRI, and as you can see, there is a dark lesion in T1, hypointense in T2, and this is the CT scan. We can see the break into the cortex, so quite aggressive with some soft tissue component. And this is the X-ray showing the progression of the lesion in the calcaneus area. This is the summary, so partially sclerotic rim on the cortex, hypointense in T1, hyperintense in T2 and T1 cassette. Which one would be your guess?
Okay. So we have 55% for primary bone sarcoma, 23% for GCT of bone, and ABC or giant cell retroperative granuloma, and nothing for infection.
Okay, this was the pathology, so most were right. There was hypercellularity, and at the higher power, we can appreciate bizarre nuclei and mitosis. And this is the immunostains, negative for H3, F3A, and also CK, Dasmin, and lots of immunohistochemistry, but the NTRK panel, which might be has been proposed prior molecular, was very positive, and so patient underwent NGS, and this fusion was detected, ML4 NTRK3. And so this diagnosis, high-grade spindle cell sarcoma of bone, ML4 NTRK-rearranged with no metastasis. Well, this is most important pool, so please take your time. Would you give this patient neoadjuvant chemotherapy as in a bone tumor like a MAP, or neoadjuvant inhibitor, or surgery upfront?
So we have 46% for the neoadjuvant NTRK inhibitor, 38% for neoadjuvant chemotherapy, surgery, and 8% for both options.
Okay, so this patient underwent a neoadjuvant chemotherapy with methotrexate, adriamycin, and cisplatinum. The lesion enlarged, but on CT scan and clinically there was like a lump on his foot, although some necrosis was appreciated. So we decided to switch to larotrectinib. I will skip this for the sake of time. And as you can see on PET scan, the lesion was highly metabolic, and this is the response after 3 months of treatment. So this is the question on surgery. Would you resect, amputate, or prefer radiation therapy or high-dose particle radiotherapy for this case?
So we have 45% for amputation, 27% for high-dose particle radiotherapy, 18% for radiotherapy, and 9% for resection.
So very interesting. We decided to go for an amputation due to the complexity of reconstruction and quality of life concern after radiation therapy on the foot, and the pathologic response was 80%. So quite good, but not enormous. So at this point, what should we do? To give him more larotrectinib, chemotherapy, or nothing? Adjuvant treatment in a case which is such a rare biology and no data.
Okay, we have 55% for none.
Okay.
27 for larotrectinib and 18 for chemotherapy with ifosfamide.
Okay, so this is challenging because considering osteosarcoma threshold, so the response is poor, but we have no data in this ultra-rare subtype. So we decided to go for follow-up, and the patient is now doing well after just 9 months of follow-up. So we definitely see, and I want to point out that this diagnosis, so NTRK fusion in bone sarcoma, are really anecdotal, so even less than 1.2%, which is the average in sarcoma. And as presented by Dr. Federman at CITOS 2018, if we pull all the sarcoma NTRK fusion positive patient, the overall response rate is even higher than in cancer, 93%. So I just wanted to show this incredible waterfall plot. But as you know, these treatments are usually performed in metastatic patients, so there are actually no data on the use of larotrectinib in the neoadjuvant and adjuvant setting. Many thanks for your attention, and this case underscore how much we should collaborate to get some clue in such very unusual and complex cases, especially in a 33-year-old boy.
Thank you so much, Emanuela. Again, fantastic, and I think it closes up the cases we saw in relation to the first patient we presented today. Now let's discuss the clinical aspect. I would love to ask the panel to switch on the cameras again so that we can see each other. Comments? Axel, Jean, Joanna, Javier.
Emanuela, how many months you give larotrectinib to this patient before amputation?
Just from July to October.
And so you have decided to stop the treatment because there is a stabilization after tumor shrinkage, or?
No, actually it was pre-planned based on the length of neoadjuvant we usually do in bone tumor, so around 3 months, and then so at the first assessment, tumor reassessment, it was just put in operating list with no consideration of any other due time.
Since
just in analogy with other bone tumors.
Since for me amputation is never an emergency, and given you give a neoadjuvant treatment to try to have a conservative surgery, why have not planned a radiation?
Because our surgeon came to our department and told the patient that no matter how the tumor would shrink, in that specific point, he would suggest to undergo an amputation, and that the treatment was just done to prevent systemic relapse.
Joy, Javier?
Yeah, I think this case exemplified the need to make genomic panels to complete the diagnosis. In the footage, the most frequent soft tissue sarcoma are synovial sarcoma and clear cell sarcoma, which are translocation related sarcoma, and in bone tumors, as this case, maybe are uncommon. So I think it's important to this type of molecular ancillary test in order to reach adequate diagnosis. So I don't know, I have some doubts, Emanuela, about the response with MAP chemotherapy. It seems the tumor, as you mentioned, enlarged, but on the other side, it seems also more necrotic or some kind of tumor response inside it, no?
Yes, actually, we consider that, but at the beginning we were unsure to use larotrectinib because there were alternatives, and so from a prescription point of view. So when we had a clinical progression with that radiological feature, we decided that we were allowed to move to larotrectinib.
So maybe
I think
we already heard. Please go ahead.
Yeah, Manuela, that's a very interesting case. I think we had some observation as well that these tumors are not so good with standard chemotherapy, and we have another example of patients who could not get to the second line because they deteriorated so quickly. We are under chemotherapy. Actually, when you look at a small series of NTRK-sarcoma in advanced phase, this is not the case, and response to chemotherapy, it's as bad as usual, I would say. So this is really an incentive to do as early as possible molecular testing, as exemplified also by case one. And after presenting your case, I was wondering what we would have done. We would probably have done exactly like you, including amputation, because 80%, okay, 80% that you treated for a small period of time, but most patients are progressing if you look at the survival curve in the PFS, actually, in the NTRK. So yeah, we have open questions to be addressed, I think.
Yes, first let's then go to the radiation oncologists among us. How do you see the situation?
Yeah, I would go for the same procedure. I really do not think that's a great idea to irradiate this foot. So we cannot express a name for radiation, you know.
I would agree with Gabriella in this case going ahead with the amputation. In terms of foot sarcomas, I think for soft tissue sarcomas of the foot, there's a fair amount of information out there about using conservative surgery and resection to get good local control and a functional foot. For bone sarcomas that are known to be radiation sensitive, like Ewing's, radiation is also a good option in conjunction with chemotherapy. Very rarely you'll see a foot lesion like an epithelioid hemangioendothelioma, which can be managed with a combination of curettage and cement packing, so you have some functional support in the foot. But many of these foot sarcomas, the real issue is whether you're going to be left with a weight-bearing foot that is useful. And I think, unfortunately, for many of the bone sarcomas in the foot, amputation ends up being the best option. And certainly the orthopedists can comment as well.
Please do that. Michael, Frank, Philip, Norbert, you're still among us. Go up the camera.
I think that the amputation is always like a big thing, but especially in the foot, because if you do a below knee amputation, the function is so good. I mean, if you see all the Paralympics, what they can do, they have nearly a normal life, except that they need a prosthesis. But the prostheses are so good that this is really a very, very good option. And it's one surgery. Healing is fast, and they up and go after 6 weeks, and after 6 months they have a new limb, and they have a very, very high quality of life. So it's completely different than if you try to save the limb or the foot. So it's a very good method or technique to improve quality of life for these patients. And I mean, the colleagues from Graz showed that even if it's possible to keep the limb, the recurrence rate and everything is much higher. So it's it's a big operation, not a tiny one, but it's rather simple, and the function is very, very good. So it's always a very good option to consider amputation.
Michael, what's your thoughts?
Yes, I agree completely. Although I had one soft tissue sarcoma in the foot that I advised an amputation, but the patient wanted to have resection, a free flap, and radiotherapy, and he's a marathon runner. So everything is possible, but in general, an amputation would be the first choice. And the only remaining question is if you would need neoadjuvant treatment if you would decide for an amputation. Of course, we can all hope for the tumor to become so small that it doesn't need difficult surgery, but in this case, probably everyone would have advised for an amputation in the beginning, in the middle, and also in the end.
Maybe a different question, where do you see the indications for calcanectomy, with or without reconstruction?
In the light of the functional outcome of a Bologna amputation, not very often.
That means nearly never, right? Okay, no, that's good. That's good. Constantino, you are among us?
Sorry?
Constantino, what's your thought on that? Okay, so there is still another question from the audience regarding radiation.
Okay, I'm here.
Tolerance of the, oh, here you are. Maybe on a comment on that. When is the indication?
I cannot say anything.
Well, just in theory.
Amputation is the first. No, amputation is the first option, of course. I think it was possible to save the foot with a very challenging surgery, maybe reconstruction with a iliac bone vascularized graft. I made this kind of surgery right now, 9 hours of surgery with my vascular surgeon, my plastic surgeons. So you have to discuss with the patient that, you can do it, but of course an amputation is easy and maybe the best option in this case.
So let's say if we opt for amputation, does that have an influence on the systemic treatment? I mean, if we say, okay, we cannot do radiation because of the, let's say, the local tolerance, surgery, amputation is the best, meaning, well, then we have, let's say, for sure, local control. Does this have an influence on the indications for systemic treatment? Javier is laughing.
Yeah, it's true. It's challenging. In the context of NTRK related tumor, is more difficult to say. In the context of osteosarcoma, it's clear the chemotherapy pretends to increase the overall survival. But in this context, maybe the aim of the systemic treatment was to reduce the tumor in order to make it more resectable. Maybe because it's unclear if we will be able to increase the overall survival with chemotherapy or even with laryngectomy in adjuvant setting. Is more unclear. If we are in the final, the aim is amputation, obviously.
Very interesting. Emanuela pointed out that there needs to be collaboration, and I think Jean-Yves, you wrote 2 years ago the guidelines for, let's say, the indication for laryngectomy treatment. So can there be a bridge? So how can this field be moved forward?
Well, the technology is here. It's really what is reimbursed for many sites, actually. It's not complicated. I mean, large number of sites have the technology. It costs because we do not have the same partner every time, so it's not a simple molecular testing. But at the end of the day, RNA-seq with a proper bioinformatic platform could be an interesting tool in routine for many, many tumors, including sarcoma. But we don't have necessarily the reimbursement by our social security systems. But who would not want
I think
to have a molecular characterization of the tumor? Everybody would want that, whether it serves or not. Obviously, it doesn't serve a lot of patients, but still.
Very good. I think that concludes now this case. Any comments, final comments to all the cases? Going to wrapping up the session.
Great cases, great webinar.
Yeah.
Yeah, many thanks.
Thank you, Bruno.
In Italy, there is maybe more NTRK genes. Alessandro Gronchi showed a similar case in neoadjuvant situation with larotractinib 3 months ago. I never seen a patient with locally advanced soft tissue sarcoma and rearrangement. So maybe Italian don't play very well football, but you are more NTRK.
Johnny.
Say it again, I did not catch it. Okay, well, thanks so much. I really love how you all contributed. It's a great webinar, great quality, great discussion. I'm really looking forward to see you again for the next case discussion in 2 months, but next month we are talking about outcome prediction. I think that will be also exciting, led by Alessandro Gronchi. Have a great evening and talk to you soon again. Bye.